Hi, everybody. It's Dr. Sloan. We're going to go through alterations in cardiac function. So we've talked about some of this in class, but not all of it. So the point of this recording is just to get you so that you feel good about part one of coronary artery disease. Remember, part two is the dysrhythmia and valvular piece. So this is separate from that. Okay, so here's your outcomes. One thing that I am going to change is you do not know how to read. You do not need to know how to read EKG strips for this class. For this exam, I'm not going to put any interpretations of EKGs on this at all. So if that helps in any way, great. Okay, so we talked about cardiac output. And cardiac output's important because that's what is actually feeding our bodies with blood and oxygen and nutrients. And so if our cardiac output is poor, then we're not going to be functioning very well, versus if our cardiac output is good, then we're going to be feeling great. We're going to be getting enough oxygen and able to have the energy to do the things that we want to do. So coronary artery disease, leading cause of death in the U.S., it can unfortunately lead to a lot of things. Myocardial ischemia, angina, MI. It can also lead to conduction defects, i.e. arrhythmias, right? So funny beats, tachycardias, bradycardias, heart blocks, etc. It can lead to heart failure, and in really severe cases, it can lead to sudden death, because when that plaque moves, it becomes an embolus, and as we know, that can be very dangerous. So the pathophysiology, like why the heck do we even make these things? It really has to do with time, age, and our lifestyle, and genetics. So there's a thickening and hardening of the vessel wall. There's accumulation of lipid-laden macrophages within the arterial wall, and lesions progress from just sort of an injury inside the vessel to an actual plaque. And then many plaques are unstable and prone to rupture even before they affect blood flow significantly. So important to know. And if you think about this, it really is something that occurs over time. We don't see atherosclerosis in children, teenagers, right? So, yeah. And they have a distinction on here of arteriosclerosis versus atherosclerosis. You don't really need to know that. Here's a photo to help you, a diagram. This is a great little diagram of CAD. And it shows you sort of a fixed stable plaque versus an unstable plaque. And we can watch this video if you want, but sort of shows you how they begin in the wall of the vessel. Symptoms. For the most part, people don't really have symptoms. Depends on the location, extent of the obstruction, but most of the time it can be silent. Now, if you have plaques in your cardiac vessels, you can then have some pain with that, especially if you have angina, where you're going to have constriction of those cardiac arteries as a result of ischemia. So the problem is with atherosclerosis is you have something in the vessel that's not supposed to be there, and it can lead to ischemia, right, which is a lack of tissue, a lack of blood in the tissues, thrombosis, which is the formation of a clot, or an infarction, meaning that a whole area of tissue and cells is cut off from a blood supply and can lead to tissue death. Partial obstruction can lead to transient ischemic events, with exercise or stress, and transient just means that it comes and goes. So you might be okay at rest, but once you put stress on the body, and you're working harder, that may be just enough to actually cause, symptoms. So, yeah. So let's talk about MI. So we know that coronary artery disease, that's different. That's really specific to the coronary arteries, the arteries that feed the heart muscle itself, that are actually on the heart itself. So coronary artery disease is very specific. It's caused by atherosclerosis. It results in lower blood supply and leads to ischemia. And complete occlusion of that coronary artery can lead to acute coronary syndrome, including infarction. So acute coronary syndrome just means that the heart isn't getting what it needs to function. And whether that acute coronary syndrome resolves because the person takes nitro or does something else, is, dependent on kind of what happens after the syndrome begins. But if they actually have, a myocardial infarction, now you have tissue death and irreversible damage. Okay, so coronary artery disease risk factors. These are important for a nurse to know because the non-modifiable ones, okay, we just have to deal with. But the modifiable ones, this is where nursing can come in and with teaching, with helping patients make changes to diet and exercise, taking medications for dyslipidemia, maybe stopping smoking, maybe losing weight, beginning an exercise program. Those things will all be very, very helpful to our patients. So, we always focus on the pharmacologic things that we can do, but we really should be looking at prevention and preventing these things from happening in the first place. Okay, dyslipidemia. Many people in the United States have this, half of the population, and by looking at someone's lipid levels, right, cholesterol, LDL, HDL, triglycerides, we can kind of say like, oh, you're at risk for developing a plaque later on down the road. So something that we want to look at. It's really interesting. Even some very young children have like high triglycerides, cholesterol, and we think that that's genetic. So they're starting to check lipid levels earlier in children. But anyway, adults for sure, this should be part of, your annual physical, and should be something that's looked at. Like I said, LDL should be low because they deliver cholesterol to the tissue and contribute to inflammatory and immune response. And HDLs, we want them to be high because they reverse cholesterol transport and participate in endothelial repair. So low should be low, high should be high, and we want total cholesterol below 200 and triglycerides below 150. Again, if you are going to memorize any labs, it would just be total cholesterol that I'd want you to know. Inflammatory markers, we want to know about these because they help paint the picture of a body that is either healthy or more at risk for something. And we often, unfortunately, don't look at these until the patient has a problem. But C-reactive protein, which is just a general inflammatory marker, it could be high due to inflammation anywhere in the body. So it's not, it's a highly sensitive marker in that it's very good at detecting inflammation. It's not highly sensitive in that it doesn't tell us where that inflammation is. But C-reactive protein, it's an indirect measure of atherosclerotic plaque and can be used to use it in context of other things with your patient to make decisions about medications that they should take. The other thing we could look at is ESR, erythrocyte sedimentation rate. And that is also very generic, not related specifically to the heart, but would be elevated with heart inflammation. Our big one that we really want to focus on for cardiac is troponin 1, and that is very specific to myocardial injury. So a troponin 1 is something that we would look at within a few hours of a heart attack, if you look at this little schematic here, and it's going to give you some good information about what's happening. So myocardial ischemia just means that the heart itself, the myocardium, the muscle of the heart, is not getting enough blood into those muscle tissues. The coronary arteries, as you know, supply blood and oxygen to heart cells. But as demand for oxygen increases, like running, walking, even sexual activity, and shoveling snow, those kinds of things. So as that demand increases, the coronary arteries respond. They're compensatory. They dilate to increase the flow of oxygenated blood to the heart cells. But if you have arteries that can't dilate because of coronary artery disease, then we have a problem, and myocardial ischemia develops, and there's not enough blood or oxygen to meet the metabolic demands of the cells. This is when we start having chest pain and start getting into trouble with arrhythmias and myocardial infarction. So heart injury, right? The myocardial cells become ischemic within 60 seconds of coronary occlusion, and myocardial cells die after 20 minutes of no oxygen. So it's going to happen really fast. Okay, angina. So angina is basically chest pain. That's what angina means. Angina means pain. And pain in the pectoris just means those are the chest muscles. So again, you have a same kind of thing where the heart muscles cannot get enough material, enough supply of oxygen and blood. And so it can cause chest discomfort. Now, this could be something that happens on the way to having a heart attack. It could be something that just happens, and once the patient rests or takes nitro or does other things, then it resolves. So just so you know, this is really just a symptom that we're talking about here, more than an actual, disease itself. So you're going to have steady, intense pain or pressure in the chest. Sometimes it can feel like crushing or constricting kind of pain. So these are good questions to ask your patient. I have pain in my shoulder or in my jaw. What does that feel like? So if they tell you it's throbbing or stabbing, you're like, maybe it's related to a toothache, versus crushing or constricting and having pain on their arm. Now maybe we're talking about MI. Pallor, cyanosis. Boy, cyanosis would be very late sign. Dyspnea, diaphoresis, tachycardia, elevated blood pressure. So these are all assessments that you can make, right? Pain is relieved by rest in nitrates. And just to remind you again that women have different symptoms than men, and it would be good for you to know these. So, they have got more gastric stuff, nausea, vomiting. They can have a feeling of panic, kind of atypical chest pain, meaning that it's not like this classic left-sided crushing pain. It might be more right-sided or central. It may be that their back hurts. And so it's something that as you get complaints from someone who sort of fits the risk profile, you want You want to pay attention to that. And actually, even someone who might be young and doesn't fit that profile, we should not be counting out, the possibility of an MI. You hear about it all the time where someone is extremely young, but they have it, and they probably have risk factors that haven't been identified, like a genetic, predisposition to, high triglycerides, cholesterol, et cetera, and they actually have a problem people didn't know. So angina is really sort of determined by increased myocardial oxygen demand. And so if you think about this, things that are critical in meeting cellular demands for oxygen is the amount of coronary perfusion and then the workload of the heart. And then here are the things that myocardial workload depends on. I don't think you really need to know these for our class necessarily, but those should be terms that if they're not familiar to you, that you look up and get to know. Okay, so 3 types of angina. Stable, this Prinz medal, which I don't care if you know about, and then silent ischemia and mental stress. All we're really going to focus on is stable angina pectoris. I'm not going to focus on the other 2 types because this is the one that is the most commonly seen, and for your young learning is probably all that you need. So stable angina pectoris is really all we're going to worry about, and it is usually relieved by rest and nitro. So unstable angina, these are things that are like new onset of angina or angina that is getting worse over time. This could occur even at rest. It's usually prolonged. Instead of just a few minutes, it could be more than 20 minutes. This is where we really worry that someone is actually having an infarct or that an infarct will soon follow. So it's something that we want to be aware of. Again, not going to really go through these EKG changes. The one thing that I would like you to know is I'd like you to know that this ST segment elevation, right, is a sign of ischemia in the blood, in the heart. And so you don't have to recognize this particular rhythm, but I would like you to know just in your head that ST elevation is part of what we call that STEMI, right? ST elevation myocardial infarction. Okay, so non-pharmacologic treatment of angina, this is good too because, again, we don't just want to throw pills at everything. We want to limit alcohol, eliminate, cholesterol, high cholesterol foods and saturated fats, really monitoring blood cholesterol, LDL, HDL, not smoking, keeping blood pressure normal, exercising, healthy weight, limit salt intake, and keep blood glucose within normal limits. Because remember, high blood glucose is really hard on the vessel walls and will cause stenosing or hardening. And so these are all the things that patients can do. And these are the things that as nurses, we can really educate our patients on and promote health. Pharmacologic management of angina, there are lots of things that we can throw at it. Beta blockers, right, which are going to slow down the heart rate and lower BP. Calcium channel blockers are going to dilate coronary vessels. And ACE inhibitors are going to decrease blood pressure. And then nitrates are actually going to dilate vessels as well. So if you just remember for those 4, the ways in which they decrease angina, you'll be in great shape. don't worry about that new drug. Let me just go back to that. That ranolazine decreases metabolic rate. That's not a drug that you need to learn. So beta blockers are friends. We've talked about them for many, many, many different things, but they bind to beta receptors located in the heart tissue. And as you know, the heart has beta 1s and beta 2s, but mostly beta 1s. And so this kind of blocks that whole sympathetic fight or flight thing, which is great because that's going to help with hypertension, MI. It's going to decrease cardiac workload, so it's going to help with angina. And with AFib, it acts like an antiarrhythmic. It just helps really regulate that nice regular beat of the heart. But again, with beta blockers, too much of its intended effect can be that we have bradycardia and that we have hypotension. We can have bronchospasm because remember, beta blockers, beta 1, beta 2, you have beta 2s in your lungs. So depending on the beta blocker, knowing that your patient has a history of a respiratory issue is key. And so I'm going to say that again. It is very important that you recognize that there could be problems with beta blockers if your patient has a respiratory issue. So it's something that as nursing students, I want your radar to just go up a little bit and be like, is it okay that they take this drug? They have asthma. Or is it okay that they take this beta blocker? They have COPD, right? So I want you to think about that. That's something that could come up on an exam. Also, it could cause heart block because, again, remember, anything that treats a possible, anything that changes the heart rhythm could be also a possible, arrhythmic. And then you want to look for cold extremities, dizziness, CHF. Cold extremities would just be poor perfusion due to poor blood pressure. So it is contraindicated with a heart rate less than 60 or a systolic blood pressure less than 100. Okay, or in heart blocks, but I'm not going to give you any examples of that. What I really want you to know is these parameters of 60 and 100. And of course, if your patient has pulmonary edema or asthma or ventricular failure, then maybe we want to sort of hold off or at least ask why we're giving it. You want to monitor for all these side effects, right? And you want to teach patients to take their pulse for 1 minute, to not chew an extended release capsule if that is the actual, medication that they're taking, and to not abruptly discontinue these medications. We've talked about this a lot. Okay, guys, one more thing I want to mention, and I stopped to actually look this up and make sure that I'm correct, but beta blockers also have an impact on people with diabetes, primarily type 2 diabetes. So one of the things is beta blockers can prolong, enhance, or alter the symptoms of hypoglycemia. Part of that, I think, is because hypoglycemia can make us feel like jittery and nervous and weird, and beta blockers really counteract that, right? It can be used for stage fright and anti-anxiety. So anyway, beta blockers can potentially increase blood glucose concentration, so you need to know that. So increase blood glucose and kind of antagonize the action of oral hypoglycemic drugs. So I would say that diabetes is right next to respiratory concerns. One of those things that should just make you think, they're on a beta blocker, but they have diabetes. I need to sort of investigate that a little bit more and make sure that's really okay. So just wanted to go over that and make sure that you guys were clear on that because I haven't talked about it before, and it is important. Okie doke. Let's see, what else do we need to do here? Oh, excuse me. Calcium channel blockers. Now we've talked about these a lot, but we have some. The goal here with channel blockers is they relax the muscle of the heart and the blood vessels. So again, if you want to memorize, the actual mechanism of inhibiting the flux of calcium ions, you can. But the important thing here is that it causes vasorelaxation or dilation. And so the use for these is hypertension or angina. We actually use calcium channel blockers quite a bit in the Black population because many folks who are Black, due to genetic reasons, do not have a lot of times do not have mechanisms that work well with like ACE inhibitors. And so we want to make sure that we're giving appropriate care based on race, because we're different, and that's just the way we were built. So it's really one of those areas where there might be inequity or maybe just even ignorance in care of certain populations. And we really do need to know whether folks are going to respond to a medication or not based on race and other factors. So something important to consider. Side effects for this kind of makes sense if you think about the fact that these are relaxing the vessels, the blood vessels, that you're going to get edema, right? Because now fluid isn't being pumped as hard through the body. It's sitting. It's much more easy for it to make that transfer over to the tissues. Nausea, constipation, headache, drowsiness, fatigue. Upper respiratory infection is really weird, but anyway. But dizziness, hypotension, those are all kind of too much of its intended effect, right? So nursing, same as beta blockers, you're going to monitor blood pressure, pulse, cardiac rhythm. The only thing here is because calcium channel blockers don't change the heart rate, you're not going to need to take a pulse like with a parameter. You just want to know what the pulse is before you take it. And I would say if the pulse is low, like less than 60, you might just want to double check before you give it. But again, it doesn't necessarily mean the patient won't get it or that you need to hold it. Okay. ACE inhibitors, we know these well. This is lisinopril, and these, work in inhibiting the conversion of angiotensin 1 to angiotensin 2, which causes an increase in renin and a reduction in aldosterone. Remember, aldosterone's our sodium water friend. It likes to hang on to that, hang out with its buddies, sodium and water. So if we have less aldosterone, we're going to have lower blood pressure. So it's for treatment of mild to moderate hypertension, CHF, or acute MI. Again, reduces sort of the workload on the heart. The side effects of ACE inhibitors, headache, dizziness, hypotension, but really probably the thing that you'll remember the most is the ACE cough. It's we know that it's caused from bradykinin buildup, but it's really, as long as the patient does not have angioedema, it's a very common occurrence, and it'll often get us to switch our patient over to an ARB, an angiotensin receptor blocker. So teach the patient to avoid changing positions rapidly, because again, this can cause orthostatic hypotension, and avoid high sodium foods and high potassium foods. ACE inhibitors can lead to hyperkalemia, so want to be careful about that. Okay, so the question when a patient has pain is it angina or an MI? Angina doesn't mean that patient's always having a heart attack. And as you know, it's treated differently than an MI. So you want to do a good pain assessment. Old carts is one of the ways you can do that. But again, I don't care if you know that for this material, but it's a way of looking at, intensity, what makes it better, what makes it worse. You can look it up if you want to know what that means. MI, myocardial ischemia will develop within 10 seconds of occlusion. So, oops, sorry, I think earlier I said 60 seconds, 10 seconds of occlusion. So anaerobic metabolism takes over, lactic acid accumulates. Cardiac cells can remain viable for about 20 minutes under ischemic conditions, but this concept of time is muscle is key. And that is why when we call like a code STEMI, it's treated like a code blue, where someone is going to be, basically there's going to be a team and they're going to focus on getting this patient to the cardiac cath lab as fast as possible so that they can unblock the blockage and hopefully not lose muscle. So just wanted to make that point. This time is muscle is a really important concept. So if blood flow is restored, we can do the cardiac cath, get in there, clear the vessel, then great. Aerobic metabolism resumes and we're good. If not, then blood flow is not restored and we have an MI. Oh, and Lacey's decided she's going to help us with this recording. Okay, onward. So acute coronary syndrome, or MI, is again where you have, hypoxia. And once you have hypoxia, you're going to actually see changes on their EKG. Again, not going to get totally into this, but two things I do want you to know. I want you to know that STEMI, ST elevation, is what we're trying to avoid because that is full thickness disease. And we talked about this a little bit in class. That's kind of like the difference between ulcerative colitis and Crohn's, where Crohn's can go through the full thickness of the bowel. STEMI is the full thickness of the heart. And if you look back at this picture, whoops, I went too far. Right here, you can see this zone of infarction. And what you're hoping for is, not something that goes all the way through to the ventricle or like a piece here where you would actually have this whole wall not working. So that's what we talk about, complete thickness or full thickness. Now an end STEMI means that there's partial thickness. So that would be the better outcome of the two if we weren't able to get the patient's occlusion fixed. So there can be this myocardial stenting, which is kind of a temporary loss of contractile function after an MI, and it may take a few days for the heart to resume its full function again. But all this craziness over here, don't worry about that. Just know that myocardial stenting can occur. And so if you're taking care of someone post-MI and they are showing sort of signs of heart failure, that may be why, but it may improve. So functional changes that happen as a result of MI is you're going to have reduced cardiac output, you're going to have arrhythmias, and you're going to have potentially cardiogenic shock. Now, cardiogenic shock is not going to develop unless a significant portion of the cardiac muscle is affected. But cardiogenic shock occurs when the heart is not able to pump enough blood out to the body. And yeah, that's just one form of shock. There's septic shock, there's hypovolemic shock, cardiogenic shocks. Cardiogenic shock is heart-based, and it's because the heart can't pump. Could be a number of reasons, but MI is certainly a good one. So 3 take-homes from this slide are reduction in cardiac output, dysrhythmias, cardiogenic shock. So 7% of individuals who are having an MI will have cardiogenic shock. It's a life-threatening emergency. If your heart's not getting enough blood and not getting enough, pumping enough blood, then you're going to have decreased blood to the brain, kidney, and all organs. And then you'll have hypovolemia due to the inability of the heart to pump blood. So cardiogenic shock kind of leads into a hypovolemic shock. But the important thing here is, what are the symptoms? So confusion, loss of consciousness, rapid heart rate, shortness of breath, pale, sweating, decreased urine output, cool hands and feet. So this is something that you'd want to look for after diagnosis of an MI, and make sure that your patient's still being perfused correctly. By the way, cardiogenic shock, this is all treated with supportive care where we, would go in and basically, try to do vasopressors and other things to try to support perfusion until the heart can kind of rebound. If the heart's so damaged from the MI that they can't recover, then obviously this is going to become a fatal condition. But in general, hopefully patients will get beyond this. So acute MI, again, don't get all wrapped up in this, but this is basically sudden death. And it's usually due to an arrhythmia or a dysrhythmia, usually VFib. So it kind of depends on how much left ventricular dysfunction they have, the age of the person, the potential for an arrhythmia. But, sudden death is sudden death. Again, we've already talked about MI and the signs and symptoms. So this again is what you're going to see. It's interesting because acute MI or a sudden, they may only have these symptoms briefly and then go down, be unconscious, or they might just go down. That might be the very first thing that happens as well. So here you go, men, women, differences. Acute MI, so looking at women, heart disease is still the main cause of death in women. So we really want to know what those MI symptoms are in patients, female patients. We've already talked about myocardial stenting. So post-infarct is sort of what's happening after the heart attack. Hibernating myocardium and myocardial remodeling. I think the most important thing here is this myocardial remodeling. So, and it happens because of the RAS system. But this myocardial remodeling is permanent. And so, you could do cardiac rehab to get the part of the heart that's still functional and healthy to work at its peak, but you are not going to change areas of ischemia or death. And so the problem here is that you're going to have decreased cardiac output with this myocardial remodeling. Again, just want you to know the concepts. Don't get caught up in the details of what exactly that is. I just want you to know that that's a possibility post-MI. So again, post-infarction period, it's possible for you to, have all of these things, necrotic tissue mixed with ischemic cells. Necrotic tissue is replaced by scar tissue. You have an inflammatory response. Scar tissue lacks the ability to contract, and there's loss of conduction, so you may have arrhythmias, heart failure down the road. I feel like we're sort of singing the same tune here. Okay. We're going to skip this slide. I don't think you need to know this at this level. Now, What I do want you to know is just to know about the troponin, okay? You don't need to know a normal troponin level. I just want you to know what troponin is, and that it regulates, it's highly specific to myocardial tissue, detectable in 2 to 4 hours after onset of an MI. You're going to check again at 6 to 9 hours and 12 to 24, and it remains elevated for 7 to 10 days. Cool. So goal of treatment, obviously, is to limit the size of the infarct. And again, here's our time is muscle concept. So you want to restore balance between O2 supply and demand to prevent further ischemia. You want to have pain relief, prevention and treatment of complications, which we've just learned there are many, and then reperfusion procedures. So things like angioplasty, stents, or thrombolytic. Angioplasty is where they go in with a little balloon and they go into the vessel with this tiny little balloon, again done through usually like a femoral artery or vein, and you thread this catheter up into the heart. You get it into the air where there's a blockage, and then you deploy this little balloon, and the balloon, as it inflates, pushes the plaques and blockages to the walls of the artery, and then hopefully, that restores blood flow. Stents are like putting in a little straw in that area, which again sort of holds all of the plaques at bay and keeps a nice open area. Or you can do a thrombolytic where it's actually going to dissolve the clot in there. So initial pharmacologic management is MONA, and I think this is a great thing for you to remember. So morphine, O2, nitrates, aspirin. And again, might not be in this order. I don't care that you know the other orders that are possible. So morphine's really good because even though it's a narcotic, it decreases pain and anxiety, and it decreases cardiac output because remember it's going to cause vasodilation. Well, not vasodilation, but it's going to cause decreased blood pressure. And so you'll have less myocardial O2 demand, and hopefully that will help with minimizing the amount of infarction. You're going to administer it slowly, IV. You're going to monitor all the stuff you normally monitor with morphine. So respiratory rate, blood pressure, their level of consciousness. Yep. Okay. Let's see. Onward here. Oxygen. So we'll do oxygen, and we'll have, hopefully, we may need to do an actual ABG if they're having, severe cardiopulmonary emergency, but we're going to put on a nasal cannula. Now, nasal cannula, really, my understood limit is that it's 6 liters per minute. That you really can't go above 6. So if you need something higher than 6, you're going to have to get a mask or a rebreather. So anything higher than 6 per minute. And then you're going to keep O2 sat up above 94%, hopefully during pulse oximetry. By monitoring with pulse oximetry. So your O2 rate may be changing around a little bit. Okay. Nitroglycerin is the next thing, and again promotes vasodilation. So again, we already know it's the drug of choice for relieving an acute angina attack, but during a heart attack, this will be good as well because it's going to dilate those vessels and hopefully get more blood to that tissue. Oral nitroglycerin or transdermal patches, those are prophylactic. So we wouldn't use a patch for an acute episode of angina. The only thing that really works there would be IV or sublingual. And there's a bunch of different formulations here that you can use, but a transdermal patch would be something more that we give, we apply every day to prevent angina. Okay. We already know about nitro. We've learned about that. So has limited ability to dilate atherosclerotic coronary arteries. I think that's really important. But remember all of the side effects and things that come from nitro as well. Having, a headache, and since you're doing vasodilation and dropping blood pressure, you may have rebound tachycardia. So can take a look at that. We already know this, so I'm going to go past that. Patient teaching, we've already reviewed this as well, but with tablets, if you're having chest pain at home, place one tablet under the tongue, leave it there till it dissolves, don't swallow it. If pain's not relieved in 5 minutes, and you're awaiting emergency care, you're going to call EMS. So it's either right after the first one or right before you take the second one. If you answered either one of those, they'd be correct. While awaiting emergency care. And then you can take one more tablet. So the max is 3. Beyond that, we're kind of hitting a point of where it's no longer really beneficial. It needs to be stored in the dark, and it usually comes in a bottle that's brown, again, because you want to protect it from light and heat, and replace it 6 months after opening. This is a medication where you can't use something expired and still expect it to work. We've already talked about this. Use gloves when applying nitro, prevent self-administration. And we talked about this a little bit. Make sure that you don't give patients with erectile dysfunction who've been taking their medications like Viagra or Cialis, do not give them nitro and their drug at the same time. It can cause possibly irreversible hypotension or death. Aspirin. So we've learned about aspirin as a non-steroidal anti-inflammatory, right? We know that it makes platelets slippery, so we want to be careful about that. We know that it's a non-opioid analgesic. It does reduce pain, so that's good. But the reason we're giving it to these patients is for the anti-clotting part of the medication, the platelet aggregation inhibition. That's really what we're going for. So again, the dose is 160 to 325 during an MI. So it would be 2 or 3 tablets, baby aspirins or chewable aspirins. And then it can cause nausea, vomiting, GI bleeding. Aspirin's hard on your stomach. It just is. In fact, if people are going to take it every day, you really want to tell them to take it with food. It can also cause ringing of the ears. So that's kind of the fourth leg in our plan here for that. And then alteplase. So we've talked about alteplase. It's a thrombolytic, and it is going to be used for many things. Can be used for STEMI. So again, remember, STEMI's bad. We're trying to make sure that we save as much of that heart tissue as possible. But this is also the same drug that we use for unclogging like PICC lines and other long-term lines that we don't want to have to pull just because they are not patent anymore. So it works really well. The onset's really quick. The biggest risk with this is just a hypersensitivity reaction to it, i.e. allergy. So, and then hopefully there will be good revascularization that occurs. Again, using either a clot buster, or here's this beautiful little angioplasty. Actually, this is a stent that's being put in. And here's some cool videos if you want to watch these to sort of see what the plan of care would be. Here's angioplasty as well. This is, again, the balloon, right? So you can see the balloon, and the stent is around the balloon, which is super cool. So they go in there, puff up the balloon, the little stent stays in there. We keep the artery open. Coronary artery bypass grafting. you can watch this and look at it. It is a surgical procedure where we actually like bypass the area of the heart that is, dead, and we use veins often from a leg or somewhere else, but it is a big deal surgery and not something that we do unless we have to. That's it, my friends. I hope that helps. I think we're pretty good. There's some questions in here. We can go through these. Patients being discharged with nitro. Patient education would include these instructions. What do you think? So your answer is B, right? Would never put 3 tablets under the tongue at once. Talk about a headache. Woo. Primary mechanism of action that makes nitrates useful for a patient with angina. Here's your answer. They decrease preload by causing vasodilation. Put the following nursing interventions in order for someone who's experiencing chest pain. There you go. Remember, ADPI, right? Assessment, diagnosis, plan, intervention, evaluation. So here's a case scenario. I'll let you read through this. You might want to pause the video. Okay, so nursing priorities. Awesome. Okay, guys, that is it. Hope that was helpful for you. Yep, contact me if you have questions.